Good afternoon, everyone. Um, my name is Naveed Noor. I'm the moderator of the session today. Um, I work as an assistant professor of health policy and system research at the Aga Khan University in Pakistan. I also have two faculty appointments with the University of Manitoba, Canada, and with the University of New South Wales, Sydney. It's my pleasure to welcome you all to the session, Understanding the Role of Gender Sexuality in Global Health Inequalities. So as the topic speaks, the title speaks, we will be talking about gender, we'll be talking about sexuality, global health inequalities. We'll not be just focusing on the deficit side of gender, sexuality, and health, but we'll be discussing some of the ways in which the lives of women, men, and those with diverse sexual and gender identities could be improved, and their health care specifically could be improved. So this is no secret that in all societies, in some form, discrimination based on gender, sexuality happens, which can produce various sorts of inequalities. For example, social inequality, economic inequality, and inequalities in accessing healthcare, which in turn can lead to inequalities in health outcomes. So we have also seen strong social scientific evidence of where this sexuality and gender-based discrimination comes from. And we individuals are not only regulated by the law and the governments, but also by the norms and values which we internalize through socialization, and in turn we reinforce the very structures such as patriarchy and heteronormativity. To create just social and healthcare systems, it is critical to trace the roots of patriarchal and heteronormative systems and find ways to create societies where every one of us is given importance and equitable access to resources, including healthcare. The promising thing is that the gender justice is on the radar of global health for now, for quite a few decades now. We have seen multilateral and civil society organizations coming actively forward to promote gender equity and justice. At the same time, there has been a great influx of research, particularly academic research, examining the factors that contribute to social injustice based on gender and sexuality. However, despite these efforts, we are still far from achieving a social environment where the human rights of people of all genders and sexual orientations are respected. Health is the fundamental right of all individuals. When discrimination happens on the basis of gender and sexuality, it brings several negative consequences for cisgender heterosexual women, cisgender heterosexual men, and all the people with diverse sexual and gender identities. For instance, the patriarchal social system affects women's access to sex education and access to vital sex and reproductive health services. The perceptions of masculinities lead to many forms of risk, which may increase men's chances of being affected by drug addiction, mental illness, HIV, and other sexually transmitted infections, and various other physical harms. Heteronormative attitudes contribute to the rejection of LGBTQ plus people, and once they are rejected by their families and communities, they may face problems such as homelessness, drug and alcohol use, mental illness, and social isolation, which doubles their problems in getting jobs in the formal market, accessing education, and accessing healthcare. Today in this session, we aim not only to discuss different dimensions of discrimination based on gender and sexuality, but also the ways through which we can ensure access to equitable health for women, men, and people with diverse gender and sexual orientations. So in this session, we have assembled the best minds who will speak about gender, sexuality, and global health from academic, civil society, and advocacy perspectives. One of our panelists, Dr. Mina Kang, will accompany us virtually from Korea because unfortunately she could not travel to Bangkok for some reason, but we are thankful for her virtual presentation in this session. We will try to keep the session as interactive as possible. and we encourage you to jot down your questions as we go with the presentations. Um, well, after each presentation, we'll try to do a critical reflection. We will ask the audience whether they have to add anything to the existing discussion at the end of each presentation, or if they would like to ask any questions for clarification. But we have a large 15-minute session for Q&A. So I encourage all of you to write as many questions as you can, so we can have a great discussion at the end. With that, I would like to invite our first panelist, Dr. Melanie Etty, to speak about gender egalitarianism in global health. Dr. Etty is a medical doctor, an academic clinical fellow in infectious diseases based in the University of Oxford. And before commencing this role, she obtained a Master of Public Health with a focus on global health at the Howard T. Chan School of Public Health. She has previously worked on research projects addressing infectious diseases in pregnancy in Uganda and Brazil, and during the COVID-19 pandemic. She worked as a coordinator of the Maternal, Newborn, and Child Health Working Group of the COVID-19 Clinical Research Coalition. Melanie.
Thank you so much, Dr. Naveed, and thank you very much to the PMAC organizers for inviting me to talk at this session. So as Dr. Naveed mentioned, I'm going to talk about gender egalitarianism. So to start my discussion, I'm going to talk a bit about women's contribution to healthcare. We'll start the presentation with a few statistics. So, and many of them you may be familiar with. So as we know, women make up the majority of the healthcare workforce globally. They make up 70% of healthcare workers worldwide. But they make up just 31% of the world's ministers of health. And this very much varies based on the region of the world that we're thinking of. So Africa actually paves the way with 38% of their ministers of health being women. But unfortunately, Southeast Asia, just 18% of ministers of health are women. Only 28% of the deans and vice chancellors of top medical schools globally and public health institutions are women. And only 20% of board chairs and C-suite members at global health organizations are women. And I say this actually to highlight that among our midst, we have women such as Professor Rhoda Wanyenze, Professor Agnes Binawago, Dr. Tessie San Martin, and also Dr. Precious Matsoso, women who've really paved the way and are trailblazers in their field. But it doesn't have to be this way. So that data actually I took from a report that was written by Women in Global Health and published by the WHO called Delivered by Women and Led by Men. And with a bit of technology, I have linked that report to the QR code. And so you can open the link and hopefully read it today. I've linked it here along with the recently published Lancet Commission on Peaceful Societies through Health Equity and Gender Equality. And actually here we've got a few copies of the Lancet issue that this piece is detailed in. But I highlight these two particular pieces because they're both quite a sobering read. It really highlights that despite women forming the vast majority of the healthcare workforce globally, they have no pipelines to progress, limited routes to leadership, and can't even secure their safety in their own society. So when thinking about what I wanted to talk about today, I thought about, I consider myself to be a feminist, and I imagine with those of you being here, you feel the same way too. But I'm sure we've all experienced expressing our views and referring to ourselves as feminism or talking about feminism, and people, balking at the thought, whether it's willful ignorance or people who genuinely don't know what feminism is and what it stands for. And so it really got me thinking about what is it that I'm actually trying to say? What philosophy am I actually trying to propose? I know that gender equality is now often the term that is used in a lot of the literature, but my issue with the term gender equality is that perhaps with it does not come the norms that we want to see in society. And so I actually prefer the term gender egalitarianism, and this refers to the philosophy of egalitarianism. You know, this philosophy that all people are fundamentally equal and should have equal access and opportunities in society, no matter their race, gender, or religion. And I would also add to that gender identity. And this philosophy is not new. This is not a modern philosophy that was, you know, created by a recent philosopher. This is an ancient philosophy that was, yes, it was brought to the fore by John Locke in the 17th century, but this is not new. This is centuries of this argument being made. And yet here I am in 2024 trying to convince you that we all deserve equal rights, irrespective of who we are as individuals. So thinking about how we move towards a gender egalitarian society, well, I've thought of three main actions that we can take. So first and foremost, we need positive action. This is not something that we can drift into unconsciously. This is something that we all need to take action towards, you know, be us men, women, non-binary. We all can make positive change towards realizing this philosophy in society. I think using an equitable approach in order to achieve equality is essential. Those who are most disenfranchised in society need to be uplifted. They need the greatest attention in order for us all to come to the same level. And also, I would say that it is important that we challenge what are considered cultural norms, and Dr. Naveed touched on this, but you know, many of the ideas that we have in society need to be challenged. And you know, I would say that some of these beliefs they take very different forms, you know, from benevolent misogyny. You know, we shouldn't stress women out by, making them work. No. You know, let's let women relax, and men can work, and women can just stay at home. To outright state-sanctioned violence against women, we need to challenge these things in society. There is no philosophy, there is no religion in history that has ever preached or advocated for violence against women. And I just think it's important that we all know that to be fact. And there are so many more actions that can be taken, and I'm sure a lot of you can speak to that through the work that you're doing. So I'll very much leave it there. I just wanted to set the scene for the presentations from my wonderful co-panelists. So I'll pass you back to Dr. Naveed.
Thank you. Excellent presentation, Melanie. I think the statistics that you have presented here are so revealing, number one. And I was amazed to see, I mean, just giving the example of healthcare, and services within the healthcare are delivered by women, but led by men. So this was so revealing. And I wonder, despite how capable women are, they're still being led by men. So I think we have to take steps in a positive direction, as you said. We have to adopt positive action. We have to use equitable approaches, and we have to challenge the cultural norms. So we have to confront heteronormativity and patriarchy that come in the way of achieving gender equity. So thank you very much. I would like to move to the audience to ask if you have any questions just for clarifications, or if you would like to add anything to Melanie's talk. Yep, please.
Hi, I'm Claire. I'm from the Philippines. I serve as consultant in different projects on gender mainstreaming. So, just about the gender equality, gender egalitarianism idea. I'm not sure if you're also you're familiar with the Convention on the Elimination of All Forms of Discrimination Against Women, because the idea of gender equality there, substantive equality, is what you have defined as gender egalitarianism, and also the approaches on positive action, equitable measures, and and going against cultural norms. That is also the very basis of the CEDAW. The CEDAW has been there since 1981. If you haven't, kindly please take a look at that, so that then you can also, enrich the CEDAW as a framework for health, instead of having to, change the terms and change the definitions. So that's just my plea to please reconcile this with the CEDAW framework, and not have to say that gender equality, there's something more superior than gender equality, because, the CEDAW has been a victory for women's movement for, how many years, and we don't want to lose the victory by saying that gender equality is, like lesser than gender egalitarianism.
I suppose what I would say, though, and I don't dispute the fact that it has been a success, but there are still millions of women who remain disenfranchised, and perhaps I bring this as an, not even really as an alternative view, but a way to really draw attention in our society to those who need to be re-enfranchised. So I hope it doesn't come across that I'm pitting egalitarianism against gender equality. I hope my slide came across that I'm broadening and adding to it. And that was certainly my intention.
Okay, so with that, I would move to Dr. Mina Kang. Would you like to add anything to the?
Yeah, if possible.
Yeah, sure.
I wanted to point out that in a consideration of feminism, Mel's mentioning how major religions don't advocate violence against women, right? But when you think about feminism, it's like, it's not a women's problem. It's like men are patriarchy. So like, what do you do to get them to shape up? And where does that fit in a conceptualization? Thanks.
So I think in many ways, that is why I prefer terms such as gender inequality, or equality, I should say, and gender egalitarianism. It puts the onus on all of us. And I think particularly in patriarchal societies, I think it's important that the onus is on men to ensure that they are also as responsive as women in society. They often wield the power to be able to bring women up, to allow women to achieve their full potential. I think so often gender equality is made out to be a woman's issue, and I just can't understand that. And perhaps I don't have the answer, but I think widening the conversation and putting the onus on men in society as well to be able to contribute meaningfully, not only to the conversation, but also to the actions that are taken, I think is an important part of this movement.
Thanks for the contributions, and thanks for your response, Melanie. So I would reiterate that at this point in time, we will just focus on just a couple of questions or reflections, because we have a large Q&A session at the end of all the presentations. So I would just try to take just 2 questions at the end of each presentation, just for reflection or any minor clarifications. I would like to now move to Dr. Mina Kang, who has joined us virtually from Korea. Dr. Mina Kang is a professor at the Department of Public Administration at Ewha Women University in Seoul, Korea. Until recently, she served the Korean government as the first female commissioner of the Board of Audit and Inspection at the Supreme Audit Institution of Korea. She is currently serving as the president of the Korean Association of International Development and Cooperation. She is an active member of W20, one of the engagement groups of the G20 focus on gender equity. And in 2022, she was the co-chair of the working group on health for the W2 G20 Indonesia. Within the education sector, she served as the Dean of the EWA Career Development Center and the Vice President of EWA Institute of Leadership Development, which provides assistance and guidance on career development for female college students. Over to Mina.
Thank you. Can you hear me?
Yes, we can hear you. Please go ahead.
Okay, well, thank you. Thank you very much. I'm Dr. Mina Kang, professor at Ewha Women's University. I have to apologize because I cannot attend in person due to some of the health issues. I'm very honored to have this opportunity to introduce my team's project on empowering women and girls. And today, I'd like to introduce and advocate a new approach to how we perceive women and girls especially when we design and then evaluate public health projects. And I'd like to contend that we must change the way we design and evaluate public health projects for women and girls by moving away from the traditional views and see them in a more positive and empowering light as enablers. Next slide, please. Oh, I will move my slide. Can you see my slide? Okay, I assume you can all see my slides. So I will go on. And sadly, as you see in this picture, it is still true that throughout many stages of life, from birth to death, a large proportion of women still goes through various adversities. In some countries, when a girl is born, her birth is not registered. And as we all know, without birth registration, girls may not have access to education and vaccination. Without certificates, women cannot vote or open bank accounts. And unfortunately, a large number of girls still experience early marriage, human trafficking, and physical and mental harassment. And there are many places where women still experience a high risk of maternal mortality, extreme poverty, and domestic violence. And most importantly, in a large number of countries, women are still frequently excluded from planning, decision-making, and lack access to critical information and knowledge and technologies. Discrimination and exclusion continue even after they die. When a woman is not registered, her death cannot be registered. So in order to address these sad realities and break the unfortunate loop, I'd like to challenge the traditional approaches to how we design public health projects for women and girls. I would like to contend that we have to acknowledge that despite many global efforts to promote gender equality, women are still seen as powerless victims or passive beneficiaries at best. When we continued to viewing women in this way, without seeking ways to provide enough resources and opportunities for them to become enablers, women will remain a passive part of our society. And here are the reasons why we should take a new view of seeing women as enablers rather than victims or beneficiaries. Melanie mentioned some of the similar statistics, but according to the data from UN Women, women hold only about only 21% of ministerial positions globally. Only 3 countries have 50% and more women in parliament. And based on data, UN Women expected that at the current rate of progress, gender equality will not be reached among heads of government until 2150, which is another 130 years. As long as we see women as only victims or beneficiaries of assistance, rather than capable actors to remedy these problems by making decisions, manage and evaluate improvements for the situation, I can easily predict that women will remain to be silent, anonymous, and only take passive roles. So here I'd like to suggest a model of women enabler impact assessment model. The model suggests an assessment model for developing public health projects based on the project's potential or capacity to promote women enablers. In the traditional impact assessment model, the main indicator for monitoring and evaluation of the impact was to count the number of women who received services or who received any products or food from a project. We suggest a different approach. In our assessment model, we advocate to use indicators that capture the proportion of women enablers who are taking active roles by actively planning, implementing, and assessing the impact of the project. Women can be enablers in various sectors over multiple levels throughout various stages in creating an impact, ranging from agriculture and water management to engineering and blockchain, using health IT, not only as decision makers, but as entrepreneurs, explorers, accelerators, developers, innovators, and change makers. Women should and can take enabling roles and responsibilities throughout the entire project cycle, from concept mapping, planning, design, validity testing, financing, implementation, evaluation, feedback. Most of all, our model intends to press organizations and project teams to actively recruit and train women enablers, as well as provide resources and opportunities for them to be enablers to lead, manage, and evaluate the impact of teams' work. Instead of just remaining of beneficiaries of health services, women can be important partners in following areas. I looked up UN job sites in the areas of public health sectors, and they showed the following various areas that women can take equal parts. There are areas of emergency relief, developing and building medical infrastructures, developing policies, procedures, and plans, and creating efficient healthcare system. As a policy analyst, women can also take important roles in studying complex healthcare issues, identifying key global health trends, patterns, and strategy, evaluating outcomes related to regulations, legislation, and resources, and gathering, analyzing data from various sources. Also, as global health consultants, women can also actively review international laws and regulations, plan organization changes, planning new treatments and technologies, and helping organizations to help shape health policy and strategy goals, and building and maintaining partnership and networking across the global health sector. Well, these are the beautiful pictures of women who work and taking active roles in women utilities, in water utilities. How do you do that? In doing so, I would like to advocate to move our focus from being gender sensitive to gender transformative. Interventions to improve women and girls' life and all our public health projects can be and should be gender sensitive if it aims to compensate for gender imbalances. However, those interventions can proceed to be gender transformative when it broadens its aim to explicitly promote women's empowerment and achieve gender equality by disrupting existing power dynamics. I'd like to emphasize that it is very important to be gender sensitive because we need to meet immediate needs of many women in a disadvantaged situation. In order to meet the needs and improve the condition of women, every woman should be provided to access to food, healthcare services, and education. However, I'd like to contend again, a more powerful and resilient approach is to promote gender transformation that is based on gender strategic interest. It is important to transform the current practice so that women can have decision-making power and control over what they have access to and use. By gender transformative, I mean improving women's position by giving them names, providing opportunities to become capable and to take meaningful roles and responsibility in planning and decision-making roles. Women can be enablers instead of victims by being empowered to have technical skills and making important decisions. Well, this is an example of AGB, gender categorization system. If we start from the bottom, number 4 is project with no gender element, and then some gender elements, and effective gender mainstream, and finally gender with gender equity theme. In order for a project to be categorized as the first top category, which has project with gender equity theme, I'd like to contend that we need to take gender transformative approach. When you address gender equality and empowerment, we need to do it not just for women beneficiaries, but more actively for women enablers. Well, let me repeat what I said in the beginning. Every woman should be and can be an enabler. We should now start counting the number of enablers instead of, or in addition to the number of passive recipients of food, healthcare, and health services. Women of all backgrounds should be empowered to assume any role of and responsibility, from designing a project to assessing an important impact of their work. I'll stop here and thank you very much for listening.
Thank you very much, Meena, for an excellent talk. And I totally agree that we have to take strengths-based approaches to empower women. So I think that the problems that are women facing, which you have oriented our attention to, like early marriage and lack of education and trafficking, and the women's exclusion from planning, it's just a consequence of women's not being given access to education and the job market, and to the healthcare domains. So I think we have to ensure that we take actions that are supportive of women education, they're supportive of women health, because we have in just 2 presentations we had evidence of how enabled women are, how capable women are. I mean, I'm going back to Melanie's presentation in which she presented some statistics. So you see the situation that the healthcare system alone, it is run by women, but it is governed by men. As you also in your presentation, you mentioned that there was an example of 3 countries where 50% of the women were in the parliament. So it is another example of how enabled women are and how strong women are and how capable are they. It's just that we have to translate this strengths-based approach not only to in academia or research, but also in policy domains. So we give women channels to grow personally, professionally, and be healthy. So thank you very much for that. I will not go to the audience as we are running out of time. I'll move to our, but please jot down your questions. We will have a large session in which we can discuss lots of elements or components of today's session. So our third presenter is Ms. Lucy Combe. She is a program coordinator at the Zamara Foundation, which empowers adolescent girls and women. In her role, she contributes to the foundation's digital media presence, using her creative expertise to design impactful graphics and reports. And Lucy recognizes SRHR as a human right, and she advocates for universal access to information and services for informed health and decisions. Her work, guided by a feminist lens, addresses systemic gender issues, aiming to create a world where women and girls thrive. So Lucy is going to be speaking about building grassroots feminist movement for health advocacy. Lucy.
Thank you very much. And maybe before I start, just to throw a banner in this, a spanner in the banner, by a quote by Simone de Beauvoir that says, one is not born, but rather becomes a woman. Well, these are profound words that really gives us our reflective mode in terms of the perspective, the feminist perspectives of the societal expectations, as well as the idea that gender roles are constructed and not inherent. Yeah. So we define feminism as queer. Feminism is queer. It's always queer. And if we have that lens, we are intersectional. We tend to look at issues from a lens of gender and not just binary, not women only, not just girls, adolescent girls, but gender expansive persons, gender non-conforming persons, and the whole spectrum of gender. And with this, I'll be speaking today about what it really looks like for collective action when it comes to advocacy for health, and building up on the previous speakers in terms of women, girls, gender expansive persons, gender non-conforming persons as enablers, as having power to change the oppressive systems, oppressive norms within them, their societies, and really looking at how community-based kind of interventions, community and grassroots kind of collective actions look like. Why does it matter? You might ask yourself, why is it important to have a very kind of a feminist lens or a feminist approach towards grassroots organizing or collecting or collective or even organizing or coalescing? Well, as it has been alluded earlier, well, it is while we are advocating, while we are organizing, it's important to look at issues that address gender disparities, especially within the healthcare system, gender disparities or issues that address or have a lens of intersectionality that tend to address issues of political consciousness of individuals, building that into ensuring that they are aware of what the issue is. Is it a policy issue? Is it an awareness issue? And tending to address that using the different strategies that are there, including raising awareness, including policy advocacy, as well as other strategies. Well, advocacy is a very complex issue, especially at the grassroots level. And it has often been, there's a thin line between awareness creation, advocacy, and most often at times this comes with not understanding the issue, right? So what are the issues what are the underlying issues that we face as feminists in the community, given the background of what feminist is? It's not just the definition that we know. It's queer, it's intersectional, it is wholesome, it covers all the issues that are bringing about gender disparities. So these are a couple of issues that we're still seeing within the healthcare system back in my country. And some of them are issues that we still face from time to time. We all know these issues. We've interacted with them from time to time. One of them is the access to services. And I'll be focused to speak about the reproductive healthcare services and how then that has really brought about different strategies, different women at the community to come together to think through how then do we promote an inclusive service provision, an environment that does not judge, that does not discriminate one based on their gender, based on their sexual orientation when it comes to access to services and resources. What does regressive and retrogressive policy environment look like when it comes to advocacy, feminist advocacy? How are we not only doing policy advocacy, but also looking at repealing or doing away with policies that are really oppressive and the pushback that comes with that from some of the anti-gender movements, anti-rights movements. What is the limited what is the knowledge base or the awareness that we have as a community when it comes to sexual reproductive health amongst the community? We still are facing limited access to this information, limited access to this comprehensive sexuality education in schools. And the awareness programs are very limited. We are still seeing disparities in the healthcare outcomes, especially for the marginalized, the minoritized groups of women in the community. And with the minoritized, it's a whole compounding vulnerabilities of these young women, of these girls, of these gender expansive people. Beyond them being identifying differently, they come from a community that has a lot of other oppressive systems, like the education, their access to education, their access to health, their access, even enjoying their rights as human beings. So these are, understanding the issue, it really paints a picture of how then do we tackle it, or how then do we approach these issues. And beyond just knowing the issue, it's building the capacities of these women. By building the capacities, we are not talking about a training, or it's a long-term kind of investment in ensuring that they have, or their political consciousness is strengthened to be able to see an oppression and call it out, see a regressive culture or norm and call it out and work around that. It's also looking at informed decision making, when it comes to choosing what you want to be in life, or to access when to access the service of your choice and how to access it. It also looks at the policies and how then do we advocate for the policies that really address the issues and are responsive to the needs, the lived realities of these women and girls. Through that, of course, there are different strategies that we have seen that are working, especially at the community level. We are seeing that grassroots women and girls, gender expansive persons, feminists are coming together to pull resources together, think through together, and saying that enough is enough, having a united front and saying this is a foundation for us to be heard, us to ensure that a change is effected at the local level. So this is very inspiring to just see this, and also it is ensuring that it is inspiring people to also join the movement, and the larger the movement, the more the impact we have when it comes to the interventions that we set out. So some of the interventions that some of the grassroots organizing or community movements are doing is they are co-creating outreaches, they are co-creating with the community members, with the community leaders, and ensuring that some of these interventions are actually palatable, or that are actually relatable to some of the communities that they're coming from. Within these strategies of community organizing is policy advocacy, and this has been spoken about quite extensively, and it tends to bring a picture of it being a central kind of strategy and approach if we're looking at long-lasting change, sustainable change, and even addressing specific issues within the healthcare system. For example, gender-based violence, maternal health care, sexual reproductive health, and also just looking at a broader way of amplifying the voices of women and their perspectives within these different gaps and issues within the policies. What are some of the benefits of all this? When we come together, when we advocate together, when we think through together as women, as feminists, and at the community level, we have a sense of a community. We have a sense of sisterhood, siblinghood, where resources are pulled together. There's love, there's shared, there's collective wellness and care. There is a broader, meaningful change that is seen. There's diverse kind of perspectives and expertise that come with that. So what then do we need to do to ensure that these movements, this grassroots movement, these community-led movements are actually sustained? One is fundraising. We've seen that while the work is driven by passion, while there is a lot of resources within the movement, like human resource expertise, there is still more that is needed to ensure that some of these advocacy strategies are actually implemented. And this can be done by fundraising through different strategies, of course, crowdfunding, application of proposals, and etc. Another strategy is long-term planning, and this will tend to provide a forecast in terms of what does it look like 5 years from now, 3 years from now. It is organized, and with an organized movement attracts funds, attracts other movements, attracts even a broader impact when it comes to the strategies. And lastly, maintaining momentum. And with this, within the movement, we have dynamics of power, and the diversity within movements brings about constant or consistency in communication, in building that team that cares for each other, that is conscious and intentional when it comes to even how we take care of our mental health, how we even support each other beyond the work that we do. So that is my time. Thank you very much, and I'm happy to take questions.
Thank you very much, Lucy. Lots of food for thought, and I totally agree that critical feminism goes beyond women empowerment. It covers people from all genders and sexual orientations. And I totally agree that in order to empower women, it is important that we recognize the biases that are produced in society that work against them. So you talk about access to education, access to healthcare, but I think we also have to recognize the role of the different forms of educations that we can provide access women with. So there's mainstream education, which is basic and which should be provided to all. At the same time, we have vocational education. We have some sort of professional education. So we have to encourage women to take vocational education, vocational trainings, to make them skilled in order to compete within the formal market. And also, I think the role of media is also important. And I think in some of the sessions today, there was some talk about the importance of social media, and just I Googled it. So there was some session about the commercial determinants of health, and I just Googled healthy Coca-Cola, and it was the top trend on TikTok. So we have to be very careful about how exactly we use media. So because there is influx of information, and people get influenced by the constant stream of information that they receive. So the role of media is really important. So I would move to the audience to see if they would like to reflect on Lucy's talk, or if they have any questions for clarification. Yes, go ahead.
Good afternoon, everyone. So I'm Kershal Nodado, so I'm from the Philippines. First of all, I'm grateful to Lucy for explaining the importance of third wave of feminism in the aspect of health. So I don't actually have a question, but I would like to give an example. So we did a focus group discussion about women living with HIV in the Philippines, and based from our results, the we found that those persons living with HIV, particularly men, have greater access to antiretroviral drugs and other facilities and support groups when it comes to when if ever they are diagnosed with HIV. However, with women, they are stigmatized for having HIV. Like for example, they would often regarded as someone who are prostitutes, but when in fact they actually got their HIV from their husbands. So and there are also having difficulty in accessing antiretroviral drugs as well as support system from other agencies or and what although what I like about these women that we interviewed, they're not just supporting they're not just supporting women as well or their fellow women, but they also support um trans women and other LGBTQIA plus fellow people who also contracted HIV. That's why the reason why I want to share this that because I want people to have an awareness that HIV is very serious and it shouldn't be also it shouldn't always focus on men, but we also have to focus on women because because they do not just support they do not just because men only work for some other jobs, but women also they're sometimes they don't just do work, but tend they also have to get home and take care of their families, and they all do a lot of things to support our community. Thank you.
Thanks. I think what you have said is a clear example of awareness and education is alone are not helpful. So we have to tap onto the structural issues as well. So we have to deal with patriarchy. We have to deal with the gender-related norms and values which have been imposed on us and which we have internalized through the process of socialization. So so when we talk about advocacy, we have to make sure that we run campaigns and we do advocacy which speaks to the structural problems and not just creating awareness among women. Yes, please.
Hi, I'm Saranya. I'm a graduate student in health communication. And I guess an open question to the panel is when we talk about women's health, it tends to be revolved around sexual and reproductive health. But there's a lot of other things that go into women's health. For example, women whose health gets neglected because they have to feed their family first before they get fed themselves, or women who are cooking all the time in the kitchen and having to breathe in all these fumes. So what is it that we can do to try to expand the conversation beyond just sexual and reproductive health?
Great question. Would any of you like to answer or respond to this comment?
I think more beyond that, there is a big movement around unpaid care. Once we start to address unpaid care for women, we will see that it start to fuse into all of the unhealthy needs of women. Women cooking in the fields, getting in her, and she inhaling all those substances. She's still considered unemployed and a stay-at-home mom, but she's also contributing and being at risk with this work that she's giving. We need to change the conversation in terms of recognizing the agency of women, whether you are at home mom or whether you are a woman in high position, that our health, the needs of all women count. And to be able to do that is what we are looking at the disparity. Where are those women at the decision-making table to ensure that you have your sister back? And then it comes back to the conversation around feminism. Having women in position is something that is very, very hard. We need to unpack that. That some women are also strong consultants of patriarchy values. What are the values that we are pushing is key when we are pushing the rights of women and pushing people into position that I consider that have a feminine presenting person, because I could be a feminine presenting person and my identity is a woman, it's a man, right? So how are we unpacking those unpaid care roles and utilizing it to push that women's role that they play in on care roles are paid for in whatever position it is, so that women can be able to care for themselves. So they cannot think that I had to care for my child and not care for myself because I have daughter, and this daughter, I am sick, but I'm going to put food on the table for my children. I don't know. Anybody can try.
Yeah, I just want to add to that. I mean, I think that's an excellent statement. And I mean, I just want to say that Western medicine, sort of as we know it, is inherently patriarchal. You know, the default is, you know, men and men's issues. And so perhaps the only part of medicine that then gets relegated to women's health and, you know, women's health care relates to their sexual and reproductive organs. I think we are slowly waking up to that fact, and there is so much, I think, in medicine that needs to be unpacked and perhaps reversed, from dosing strategies for treatment of HIV, which the studies for which were primarily done amongst men and didn't factor in perhaps that dosing for women would need to change. I think this is something that people are slowly waking up to and certainly needs to be addressed going forward. And I think it's an excellent statement.
We have one more comment, which...
If I may.
Sure, and after
Yeah.
that, we'll move to our fourth presenter. Please go ahead.
So I think that was a very important question about women's health being reduced to sexual and reproductive health. And I think some of the responses which came from the speakers are really valid. I do want to make 2 or 3 points. One point is that, as you were saying, that medical education is on men's bodies. That's the standard. And that's been the feminist critique of, or the sexist bias in medical education and in medical practice. So I think it is extremely important that gender be integrated into medical curricula so that women's bodies, men's bodies, and other bodies are uniquely treated so that medicine is taught in a holistic way. That's point number one. But I do want to say that sexual and reproductive health is political. There's a lot of silence around sexuality, and especially around women's sexuality. And so even if we do privilege sexual and reproductive health, I think there's a political stance that we're taking. And I think that's extremely important. So I'm not pitting one versus the other, but I am making a case for sexual and reproductive health and rights to be honored and to be given its place in order to break all of these barriers and taboos around, especially women's sexuality. I mean, there are taboos around all kinds of sexuality, but women's bodies are controlled by societies, by families, by communities, and I think it's extremely important that women's bodies be given back to women themselves. The third point that I wanted to make also, I mean, I really want to concur with this whole thing. We do talk about these women in leadership statistics and indicators. They're important because I think they're showing the kinds of opportunities that women get to rise to those leadership positions. But I agree that I think we need to unpack that and go and comment on it. I mean, even as we are speaking of women in leadership positions, I think we need to follow that up by saying that what do women in those positions actually do? Are they perpetuating the same kind of patriarchal, policies, norms, instrumentalizing women, or are they doing gender transformative work? So, thank you.
Very, very valid points, and thank you very much for that. Would any of you like to respond, or should we move to the next presentation?
I just wanted to say thank you. That was perfection, nothing further.
Right, with that, so now I would like to invite our fourth panelist, Dr. Alicia Miraj Bass. She's an HIV prevention scientist by training with a focus on social and behavioral sciences and community health. Her expertise is in lifespan approaches to HIV prevention and sexual and reproductive health more broadly. And most of her recent work has focused on young adults of color who identify as LGBTQ+. She has led global projects funded by entities such as NIH, CDC, and USAID. And she's also a scholar of decolonization of global development. Also, she holds faculty appointments at several institutions, including Duke Global Health Institute and the University of California at San Francisco. She's going to be speaking about the lessons learned in decolonizing sexual and reproductive health work, youth of color who identify as sexual or gender minorities. Alicia.
Hi, everyone. Thank you for being here. Thank you to the organizers. Thank you for the really rich conversation that has happened thus far. And so what I want to do, everyone, is just offer something at a slightly different level of perspective than what our speakers have used so far. So I think our colleagues so far have really described the really large structural and systemic issues that women are facing, and women in the most inclusive sense of the term. What I want to do today is to just offer a very zoomed in perspective of what I have seen this look like and feel like for those of us who are experiencing some of the worst of a lot of these power imbalances and structures. Now, in order to do that, to speak to the lessons I have learned, I have to speak some more to who I am in the first place, because I think that when we do global health and development work, when we talk about decolonization, we would be remiss not to acknowledge positionality in the first place. It matters who you are in the first place to be doing this work. It matters who chose to be in this room today to be a part of this conversation and who chose not to, right? So if I'm going to talk about positionality, I want to first state my own. So you heard my resume before, and I love that, Navi. Thank you so much. What I want to do is talk about how I identify instead. And that is as, yes, I am a scientist at a US-based INGO. I do hold 4 faculty appointments at large, well-known US universities, but well beyond those things, I'm a first-generation American. I am a child of the global South. I'm the child of immigrants. I am a cisgender woman. I'm an able-bodied woman. I identify as heterosexual, right? I speak English as a native, but I also speak other languages, and I was told not to speak those in public because then I would have a heavy accent, right? So these things I experienced, the way I grew up, where I grew up in a very racially and culturally diverse area of the US, they're huge aspects of the work that I do and why I choose to do it. I cannot discount them. I can't pretend they aren't there. And as a scientist, so much of what we're taught to do is exactly that. So the first lesson I want to share and offer today on a zoomed in level about how to uplift issues of gender and marginalization is that your positionality matters. And if you really understand that, then you know there is no such thing as objectivity. We talk about it all the time in science. It's one of the biggest lies. Even when you have a randomized clinical trial, the sources of bias, who's looking at the data, who's deciding which questionnaires are included, which clinical outcomes, which are funded, which are not, there's no such thing as objectivity. There's no such thing as neutrality. I really wished we talked about that more openly. And I think when you recognize that, that's the first step to recognizing the biases that are just baked in, not only to the way that you might go about this work, but in all the work that you see, in the way you consume the things that you learned in this conference of PMAC. So I think it's a really important lesson that bears repeating. And you'll see throughout my few slides that I offer questions to ask because they're questions I ask myself. And I think that that is a place to start when it comes to actions we can take. I think action starts with asking and asking different questions and thinking about different answers. So because I do work that focuses on queer youth of color, and that is the term that they prefer, it's partly because queer is inclusive in the sense of both sexual orientation as well as gender identity. So when I use that term, it's not because I decided to. Hope that makes sense. So a question I'll often ask myself is, am I only focusing on the needs of youth in this work? Is there something here? Is there a consideration that I might need to take further that specifically looks at queer youth, that specifically looks at queer youth of color? Am I honoring their intersectionality, if that makes sense? Second, if I do that, what's the difference? what is the consideration that I can now further contribute because I'm looking specifically at the experiences of queer youth of color? And beyond that, how do I recognize and acknowledge I shouldn't always be answering those questions? Who can help me answer those questions, right? So how might this work that I'm doing, whether it's sexual reproductive health or more broadly, better include the individuals that I'm supposedly serving? Because I don't hold their lived experience. I've never in my life been a queer youth of color. So how do I bring them in as decision makers? And how do I make my accountability to them, not to funders? So that's my first lesson I want to offer. The second is that history is past, present, and future. And I just want to go back to yet another rendering of an elephant really quickly. I know everyone's probably tired of those through this conference, but in my personal view, this is the elephant in the room for all of us. Even if the geography of your particular country does not have elephants, these are the elephants in the room all of us are navigating. And that's actually irrespective of positionality. Now, because I've been a scholar of decolonizing global health and development, then I know that, and all of us know, there's a legacy of colonialism that is very much to do with why our industries exist, why they are industries, how they function right now, and how they will continue to function unless we undertake transformative action. Now, this particular elephant is not a rendering of my own making. Madhu Pai, who is one of the foremost minds of decolonizing global health, rendered this. I just added a couple things for consideration, everyone. So if we understand the legacy of colonialism and now its reiteration as neocolonialism, then we understand that patriarchy and gender inequity and heteronormativity are absolutely interconnected to racism and ethnocentrism, are absolutely interconnected to white supremacy. And people have these visceral reactions to these terminologies. But when we say these things, it's not to offend, it's to acknowledge the literal, obvious elephant in the room. And we have to get more comfortable doing that. We cannot constantly placate because people are uncomfortable with a topic or an idea. We need to be uncomfortable. Being comfortable has gotten us here, and frankly, we're not doing everything well. So we need to be comfortable understanding these harmful, problematic terminologies and also the interconnected nature of all of these structures. So I think a first step for me that's been really helpful is that for me to start acting and asking different questions and being different in my work, I had to start speaking differently. So I don't mean in speaking English versus Spanish or versus Jamaican patois or Italian. I don't mean that. I mean in the language that I choose to use for the people that I wish to work with, represent, support, advocate for, etc. Are we really vulnerable? Like, were we born that way? Is that a character trait that any person that you work with or that you were supposed to serve would actually identify themselves as? Right? So when we talk about vulnerability, they are made vulnerable. They're not marginalized. They are experiencing marginalization. They are put on the outskirts of society, right? So we need to be really mindful of the language that we use because it is very much reflective of our thought process and the norms that we need to really start questioning. So I just want to put out there, that's a lesson I think I've learned the hard way. And that's why I made mention of the fact that the youth I work with, they prefer queer youth of color. They don't resonate with any of those letters that we love to throw around, LGBTQ+. They don't want to identify as any one of those things. They might feel all of those different identities at different points, and we need to be okay with that. We're too comfortable with siloing and putting buckets on people. It's for the same reason that the youth that I work with don't want to identify as Black or Latino or anything else. They identify as people of color, and you don't get to tell them what label they have to put on top of that. So the language and the way that we speak has everything to do with starting to act differently. So we can ask, as an individual, how can I manage those biases? How can I interrogate the language that I'm using? How can I use different language? Who should I ask about the different language that I should use? Maybe gender equality is appropriate in one section or in one context or in one framework. Maybe gender egalitarianism is more appropriate for a particular orientation, particular group. They don't have to fight each other, but we have to at least be willing to have a conversation of what we mean. And shared meaning making only starts when we start speaking up and asking these questions. I want to throw out this really quickly. The historical legacies and power imbalances affecting this community, which ones are they that I may need to acknowledge and rectify? I call this out in particular because for some of these individuals, they've never worked with me as a researcher, as a scientist, but the second they saw my Duke badge, it was over. I may not have been the one myself who perpetuated this historical injustice, this racism, this sexism, this gender exclusive approach. But I might need to answer for it. I might need to acknowledge and say, I'm so sorry you're constantly misgendered. I'm sorry you're constantly marginalized. Are you willing to work with me to think about different ways to go about this work? And then, you know, my colleagues really presented powerful, impactful data. And I've heard so many sessions talk about this. I can't say this enough. We have to decolonize data. History is written by the victor, and the same is true of data. What we measure, what we consider to be a problem, where the solutions lie, who defines them, who measures them, who tracks them, who funds them, who writes about them, where they are published, the open access fees that we pay just to publish, all of that is so colonial in nature, it's insane. We have to decolonize these processes. We have to ask ourselves, who defined these problems? Are they the ones who get to make the solutions as well? How are communities benefiting from being a part of our data collection processes? What ownership do they have? When are they going to learn the results in the process? And then lastly, how would the results be different if the people who helped define the questions were also helping to draft the solutions and deciding who needs to hear that information and what should be done afterwards? So I'll leave it there, and I'll invite everyone to ask if there are ways they might advocate for youth of color who identify as LGBTQ. Thank you.
Thank you, Alicia, for such an enlightening talk. And I'm sure our audience also has some reflections on what you have said. So I would like to move to the audience and invite them to reflect on or ask any question to clarify anything to Alicia.
I have a statement to make, if possible. Oh, you can go ahead.
Yeah, so we can take the question and then you can keep your statement to the end. Yeah, please go ahead.
I just wanted to, I guess, ask for advice. In my experience talking to healthcare professionals, they tend to kind of reject queer people because they say it's not biological or it affects the way they treat their patients. So I guess, how do you change the mindset that healthcare professionals have in their approach of treating patients who are queer?
Thank you for this question. So I would offer that there's no one thing you're going to say to change entirely a mentality of that nature. But I think what you can do is counter and give consideration points that maybe this individual is not familiar with. The first would be race is not biological. And we are constantly inundated with data and literature that's supposed to be making the case that it is. It's not. It's also completely socio-political and different depending on where you are, right? We often have healthcare forms that will ask you your race and your ethnicity. Should that matter? We're so comfortable with that as a construct that we don't even question. Technically speaking, it should not matter what my race and my ethnicity is, but it 100% does. The same is true. I would try to draw those parallels for these healthcare professionals, that these other things that you've decided are biological or not, you've now have been so ingrained in your curriculum that you've decided there's no way to do your job without knowing these things. That's how you need to consider sexual orientation and gender identity. It's not an opinion. It's not a lifestyle choice. It is a fundamental determinant of the healthcare that people experience, and it's not by their choice, it's because of societal structures. So I would offer that as a way to maybe start the conversation. Thank you for this question.
Sure.
Hello, everyone. My name is Dr. Lorenzo from the Philippines. I'd just like to make a comment and a question regarding gender. Thank you so much for raising the need for advocating for gender minorities in research and advocacy. But there's also a need to advocate for that in terms of healthcare policy and how you practice healthcare. For example, in the Philippines, I've seen a lot of patients who want to transition using hormones who don't know where to go because a lot of the experience in aging healthcare professionals do not accept them. And they obtain the hormones from not so good sources. So that's a bit sad. I've also seen a lot of patients who work abroad and migrate who stop their treatment because the country that wants to accept them mandates that they have to be male again or female for that matter. So is there ways that this can be from the top to bottom approach, coming from the WHO globally and then to the regional offices, down to the country offices, influencing societies, so that finally these patients can have a good relationship with their physicians, or would be able to safely access healthcare. And I don't think gender was ever a priority in these discussions, for example, in the assemblies that we've been following through these years. Thank you.
Thank you. So I'll invite my colleagues if they'd like to comment as well, because I think all of us have things we could speak to with regard to your question. And thank you for it, by the way. So the first thing I want to call out is that there are many policy level initiatives that have existed at different points in time to try to call out the need for more inclusive policies and requirements around healthcare. The thing is, all of these things happen in context. And while you're right, WHO can absolutely put out more guidelines since they already have some, the geopolitics piece now comes back into play, right? So if I give an example in the United States, we do have the Healthcare Equality Index that specifically allows healthcare systems to be rated on how well they do with inclusiveness and inclusion of LGBTQ plus patients. Some of that is informed by WHO policies, but a lot of it is really informed by US-based policies and US-based movements. So we have this issue again of where there are these more global reports and recommendations from many organizations, from the UN, from WHO, from World Bank. I've even seen some reports, Global 50/50 report, lots of different entities. But that's where the geopolitics piece comes back into play, that there has to be grassroots advocacy, there has to be politicians as well as healthcare folks and scientists working together to uplift that, and then to bring it back to policymakers to put pressure, because the actual implementation of this work, it's geopolitical. There's no way to say, well, the work that's being done in the Philippines can directly affect the US without this type of kind of organization. And the other thing that I'll say just in my own experience is that a lot of times advocacy is not necessarily on the front lines holding signs. And I would love for us to all think about the ways that we could better advocate for understanding, like, that even if geopolitical barriers are happening in terms of healthcare delivery and financing, et cetera, the social movements that are happening, the connection of queer youth of color who are leading a lot of this charge and better connecting them in different contexts and communities, it's the most powerful organizing I've seen in the work that I have done, is having youth connect to each other to better share resources, to better share recommendations, to support each other in advocacy. A lot of times on social media, a lot of times attending these kinds of meetings and speaking, that kind of organizing is one of the most powerful things that I have seen that helps to address some of these issues. So thank you for that question.
Excellent. We'll take Melanie's statement and then move to our final presentation.
Gosh, I'm even sorry, I was mesmerized by what you were saying, and I've even sort of forgotten my point. Maybe I'll pick it up a bit later. It was something to do with the data, but
Okay.
I'll think about it.
Sure.
I just remembered.
Okay.
Sorry.
All right.
So, I mean, I just really wanted to highlight. So I drew attention to the Delivered by Women, Led by Men report that was written by Women for Global Health. And actually one of the key limitations that they highlighted in the report was actually a lot of the data was from the global north, from experiences that have been recorded from women who live and work in the global north, and that actually, you know, there are a lot of barriers to collecting information about discrimination and the experiences of women in the global south. And so, you know, I think moving forward, that is definitely something that I think we should be seeking to document, to catalog, and also to work forward from. So that was just something I just wanted to
Yes, that's so important. Thank you.
highlight.
Yes.
Right. Thank you, Melanie, for adding to the reflection. We'll now move to our final presentation. I would like to invite Ms. Naomi Tule Sholanke. She's a passionate advocate for women's rights and social justice. As a dedicated feminist and human rights activist, she has been at the forefront of humanitarian efforts in Liberia, focusing her energies on improving the lives of women and children in some of the most marginalized communities. As the founder and executive director of the Community Healthcare Initiative, established in 2014, Naomi has played a pivotal role in delivering healthcare and social services to those in need, specifically in areas that are difficult to access. In her talk, Naomi will be speaking about the role of gender and sexuality in global health inequalities and how to address biases and promote inclusivity. Naomi.
Thank you. I think after all this brilliant presentation, I can just wait for questioning, right? Good to be last. Okay, thank you for the introduction and happy to be here. I own no copyright studies, beautiful pictures that will be displayed here was used to amplify the work of my brother and sister who have claiming body and anatomy for their rights. And these are the campaign materials I'm using today. And yeah, Alisa left a question and said that, will you support youth of color that are LGBTQI? And most of the questions that have come on is mainly around sexual identity and sexuality as it relates to global inequalities. One of the things that crossed my mind immediately when I was asked to present on this topic is that most often when we talk about gender and sexuality, we forget about the critical role that global health play. Most often our attention is drawn to government, position, power, and we forget that there is a greater health need that is being left behind, a greater population that struggle for just basic health services because someone who is sitting at that position decided that the religion said that when you come as a feminine presenting person, you are supposed to be a woman. And when you come as a masculine presenting person, you are supposed to be a man. And they went to school studying that, and they are not going to change. How are we unpacking that in terms of all moving to a very, very healthcare for all, a very equitable healthcare that doesn't discriminate is very, very important. And how are we addressing our biases and promoting inclusivity in global health initiative? The challenges that I don't think this is a challenge, and I don't want to consider it a challenge, or the biases that people sit in and feel that to understand gender role as a medical practitioner or as a health professional is so challenging. It is not. It's because you have chosen a side, and this side you have decided to be very, very biased and discriminatory with the role that you are given. And we see that most often gender and sexuality often determine access to healthcare services and health-seeking behavior and health outcomes. For instance, women in many society face barriers to accessing healthcare due to gender-based discrimination, while individuals identifying as LGBTQI+ may face stigma and discrimination that affect their health outcomes. How do we address biases? Over the years, we have seen that people have to protest in my country. We have to push for a woman, a person, a feminist to take a particular role. That's the only way we're going to have success. And I think that strategy is good, it's short term, but we are not going to win with that strategy. We need to have people changing their mindset. We need to ensure that you don't have to be a feminist to be to a space before you accept that power is in people and everybody's rights should be respected and protected. We need to put human being first. And because we are not putting human being first, we are struggling. And this struggle is affecting the life of human being. Most healthcare providers, I will start with I'm a nurse by profession, and I work in a clinic. I run my own SRA, HRA clinic. And I was surprised a couple of years ago, that was then. Now we have system in place to ensure we have the right people being employed. I had one of my favorite staff that everybody wanted to go to, talk to in terms of counseling around SRA, HRA. This individual was a strong custodian of patriarchal value, had her religious and traditional biases that were affecting our clients as accessing our clinic. And because we didn't put system in place to check that, we assumed that everybody working in our facility that were providing care to key population Women living and affected by HIV and AIDS understood the issues of human rights. I say that to say on the same issue when my sister raised about when we have uh, a specific gender in a role and we feel that it is the answer to our problem. No, we need to assess our systems when we have whoever is the gender in that system. When you, the same standard you use when you employ a man, use that same standard when you employ a woman, because there are people who are custodian of the values and they affect human lives. And I think more importantly, I wrote something here and said that it should involve training of healthcare provider to recognize their prejudices as well as implementing policy that prohibit discriminatory practices. Yes, these are all good. But again, I come back to scrutinize my own presentation and say that these are things that we write and we say, but most often it comes back with the mindset. We need to change our mindset. If we are not working on our mind as individual, whether you are from the civil society or you are from government, or you come from a place that influence power, you are a donor that have funding that want to help, you don't have the right mindset and working with the right people, we have all these troubles and these struggles as it relates to inequality. So promoting inclusivity, this is the most important part. I strongly feel that global health means that we need to ensure that all individuals, regardless of their gender or sexuality, have equal access to healthcare services and enjoy some health outcomes, the same health outcomes. That can be done if we want to achieve that. We need to ensure that we have policy in place. Most of our policy in countries need to be amended. I will talk to the donors in this room. When we are carrying projects to countries that we feel that need help, we need to look at the laws that are on the books. Are the laws friendly to the work that we want to do? How can we mobilize and work with civil society to ensure that the push for the amendment of that law that will help to suit the work that we want to do? Because most often we see there's a great funding coming, great initiative, but the laws of that country is not supporting what you want to do. And over, you're going to put that resources in that country, and that country is, the laws are very discriminatory. The laws are against the rights of people. And how are you influencing that government to change the laws is important, because your grant will expire and you will leave. Maybe while you have that funding, people can operate and they can work because the funding is available. But when you leave, those same groups that you wanted to help begin to suffer because the funding influence have left. But when we put in laws and policy and ensure that we have people monitoring, documenting, and reporting as it relates to international instruments, my sister talked about the CEDAW, we talk about the UPR. There are so many international instruments, and in Africa, we use the Maputo Protocol. There are so many international instruments that we have that support health, sexuality, health equality, and we need to use those international instruments to influence government to change the legislation that support the people within the country. And I just talk about policy and advocacy. That's the same. A lot have been said about research and data here. Yes. We can't continue, and that's why I was intentional not to put any data in my presentation. I can't continue using the data of developed countries to talk about the issues on my continent, when the issue of my continent is not the representation of what is being published. Who are those publishing those data? What is the influence that they have against the population that they are publishing the data with? Are they using it to just raise money? Are they using it to maintain a job? Are they using it to ensure that we are suffering, we are in a poor country and we need help, and that it helps, the white savior is coming, and these are the data the health savior need to save us. These data represent human beings, and we need to ensure that we are working directly with those people who are affected. And most often, as from the civil society background, I always push that we need to continue to work with the bottom-top approach. The people who live in the situation, before crisis happened, before inequality happened, they are living there. During inequality issues, they are there, and after they remain to stay and build back the community. Once we have the people on the right path with us as we change policy, change and legislation, we're going to see there will be a shift in data collection, and people from my continent will be able to change and control what the data are and what the data means to them. So inclusion and beyond, there's no other way we can overemphasize than what all my my fellow panelists have said. We need to understand that the role of gender and sexuality in global health inequality is key to addressing biases and promoting inclusivity. That means a multi-pronged approach that includes policy change, advocacy, and research from the continent, research from people who are affected, research of people who live every day the harsh reality that we publish. We need to ensure that women from the grassroots are part of our data collection. They are leading on. They have the agency, they have the capacity. Let us invest in it. Let us invest in youth movement, local youth movement. Let us invest in grassroots movement to ensure that the data we are presenting, we are not presenting for them, they are presenting themselves, and they are articulating the issues that affect them themselves and demanding for the change that is required. Thank you.
Thank you very much, Naomi, for your presentation. I hope there is somebody who want to reflect on what you have said. So please go ahead.
Thank you so much. And not just Naomi, actually all panelists. First of all, thank you so much. I feel a giant sense of relief, actually, being in this room with you today, because until this moment, until this session, everything that we've talked about with gender in this conference that I've participated in has been very binary. Even so much so that in the last plenary session that we just came from, we had our trans sister from Philippines stand up and ask a question and was really just dismissed. You know, well, of course you're participating, you're in the room. Anyway, I want to go back to the decolonization discussion and intersect it with the conversation that we're having today about inclusion of LGBTQ people and leaving no one behind. You know, we're in this really crazy cycle quandary when it comes to discussing decolonization and LGBTQ people, because in many of the countries where I work, at least, oh, sorry, I should have introduced myself. My name's Hallie Mahler, and I'm the HIV director at FHI 360. And as part of that, we also have quite a large program on LGBTQ rights and inclusion. So just so you know where I'm coming from. So, you know, in many of the places where my team is working, you know, we're being told, of course, that LGBTQ is a Western, Northern export to countries that we're working in. Of course, LGBTQ people have always existed and always had extremely important roles in every society on Earth. And there is, you know, nothing that's exported. Ironically, you know, so it's a colonial construct for some people in their minds. Ironically, it is the folks in the United States who are actually perpetrating this perspective. You know, the religious right and other folks coming to countries and actually making that narrative the narrative, helping to contribute to that narrative, working in tandem with local folks. So how can we get out of this terrible cycle when it comes to talking about colonization and LGBTQ people? How can we work in the countries where you're working? Sorry, I'm going to leave the United States out of this for right now. But other countries in the world where we can come forward, talk about what the role of LGBTQ people are, discuss colonization and decolonization, what our history is and what our future is. Anyway, I'll leave it at that. It's something that I think about a lot because we do have funding from democracy and governance folks, not just the HIV folks, you know, asking us to support movements, particularly in Africa, but also in Asia. And this is a quandary we face every day. So thank you.
Thank you. Could we take questions one by one? Because we want to cover every aspect of what has been asked from the panelists. So I would encourage that we take questions one by one. So that question is for all the panelists. Who would be interested to go first?
I think I'm on, right?
Yep.
I struggle with the issue, and this is my own personal struggle in terms of not looking at human being as human being. Because when I look at people, I see human being. But the fact that we have to struggle with people's sexual identity, it is a problem for me because I feel that in my country we call it you are too nosy. Because it's not being judgmental, right? You are just too nosy, right? We need to look at codification. What codification is, what your needs are, what are your rights are. No matter what your presentation, we should look at human being, look at people's rights, look at their needs and address it. It comes to what she was saying about being on medical, when you start to look for races, what's your gender orientation, and that's why biases starts, right? We need to unpack that. We need to look at the needs of human being. When you look at the needs of human beings, these are the main strategy the women's rights movement used. They were like, look at all human beings as equal. And then when feminists came in, we're like, yes, there are people beyond just men and women. There are people with their own gender orientation. Respect it. So I think respect in human rights is one of the things that we need to internalize as human being. And once we do that, it's easier for us to understand diversity and intersectionality. We are struggling, we are putting ourselves in too much struggle, understanding with our own biases. So for me, what have helped me talk to people with their deep biases, but sit in public offices and have to provide services to everyone, I'm like, you are giving yourself the trouble. You need to respect human rights, you need to respect diversity, and look at people for what their needs are and what their rights needs are. It's just one of the ways.
Yeah, maybe just to go and say that in our context, it's contextual in how we perceive inclusivity and even how we take it and, appreciate it. Within my context, it's very hard to say that we can openly talk about, or yes, we are doing that as advocates, as civil society, as women rights organizations. But it is very hard because it is criminalized within our law. So it is not as easy as saying, yes, we can talk about this. Can we enact this? Can we have this can we decolonize this from bottom up, from top to bottom? Because it is very contextual. It is criminalized within our penal code that if you have same-sex relations, you are punished. The punishments are very harsh, and the communities beyond the laws, beyond the legal frameworks, it looks at the cultural backgrounds that are very strong within our context, that they perceive such conversations as westernized. And it is very hard to ensure that they are understanding the issue. Yes, we're making strides with our advocacy efforts, with working with the communities to ensure that the narrative is shifting from that regressive one to a progressive one. But it is a step that, of course, we're not there yet. Unfortunately, we're not there yet, but we appreciate that advocacy and more power that is given to women to ensure that we are actually speaking in one voice. We are demanding for this inclusivity, not to specifically say LGBTQ in front of maybe a government meeting, but to say words like, or in all their diversities, women and girls in all their diversity. So in the language also that we use when we're speaking to these policymakers, these decision makers, to ensure that they have a buy-in or they also support some of the works that we're doing. So it's a challenge, of course, that we are slowly becoming, or we're slowly advocating and making strides, but we're still a long way to ensure that this is uniformly or wholesomely appreciated even by the decision makers within our context. Yeah.
Thank you. Would anyone else like to add anything?
I'll just give a brief comment, and I want to say, Holly, thank you for starting off your question by talking about a little bit about your positionality. I think that's important. I want to say this really quickly. I just want to offer that not every message can be carried by every messenger. So if we're going to have an honest conversation, it may not actually need to be us that's having the conversation. We might need to create a platform for it, but we may or may not need to be the ones that are really driving and leading it. I'll give a very hands-on example. So My esteemed colleague, Dr. Rhoda Wanyenze, and I have been working for years now to understand and bring a conversation of decolonization and global equity and development to a large consortium of partners, right? We have done a white paper, we have a publication, we went on our press tour, so to speak, and one of those sessions was held at Dr. Wanyenze's institution, Makerere University. And when we were designing the flyer, we had a very honest conversation about what language needs to be on here so we don't wind up referring to terminology that's going to immediately bias people against being in the session because they're now associating what we do with pushing an agenda of LGBTQ plus identities, right? So Rhoda said, we're not using this language. We're not playing semantics. We're not trying to control the narrative or the conversation. We're understanding that the way we might want to come into the room and have the conversation is only going to be possible if there's certain language we might refrain from, shared understanding we try to have with the language that we choose to use, and not driving the conversation. We were there to kind of come into the room, see how to be helpful, and just keep quiet the rest of the time. So I'll just put that out there, and I'm happy to talk more about this later.
All right, so we have 15 minutes left in our Q&A session. I would move to the audience because we have one person lined up at the back first. Yep, thank you.
So first I wanted to say, I thought this was a brilliant panel, so congratulations. I'm very happy to be here in this room. I just wanted to add 2 points. One is a larger contextual point of the anti-gender and the anti-rights movements which are resurging in several of our countries. And I think that has to be acknowledged. That is a reality. And that's the larger context in which we have to frame our organizing. And I think it has to be really lateral organizing and building solidarity, like what you were saying, you know, the youth reaching out and organizing themselves. So that was the first point, that there's a larger context in which our struggles are situated. The second thing that I wanted to say was that this is also a health systems issue. Gender responsive care, which has to be provided, or let's say, I don't want to use the word patient, I don't want to use the word client, person-centered care is a professional ethic of the healthcare provider. And I think that is something, you know, so the point about everyone who comes to you is a human being, but how do people understand that? It's a bit abstract. And what we found in our country, some of us have been working with value clarification of healthcare providers across the cadres around different issues: violence against women, abortion, youth sexuality, you know, gender transformative, gender responsive care, LGBTQI, how do you sort of respond to them? How do you create space, safe enough space where they can disclose themselves, you know, where they will not be stigmatized or discriminated against, all of that. So I think that there is a place for insisting that value clarification be made part of all health curricula, healthcare provider curricula, basic as well as ongoing. So that is something that I wanted to just put forward here.
Thank you very much. Would you like to respond, any of you? Any response?
Yes, I mean, to your point about this being a health systems issue, I mean, I couldn't agree more. And I think the COVID-19 pandemic highlighted that. You know, we talked a lot about health systems resilience during that time, but women were disproportionately affected by the shortcomings of healthcare, the closure of you know, sexual and reproductive health clinics during that time. And the effects on their lives were huge, you know, and I think it's just important. I know we don't want to lean towards purely defining women in terms of, you know, their secondary sexual organs, but I think it is important, as you mentioned earlier, that we do recognize that actually this is a part of care that women so desperately need and is essential to their well-being. So I couldn't agree more.
Exactly. I think health system does play out a role in addition to other structural problems including patriarchy, heteronormativity, and the law. So one thing that we are missing out on is the the people who identify the people who have diverse sexual and gender identities, are of color, and have faith, right? So there's strong evidence from various Western countries is that LGBTQ plus people who have faith, and particularly who are Muslim, they're not able to access healthcare services because the healthcare providers believe that religion and queerness contradict each other, and they're not culturally competent to provide them with customized care. Um, and therefore, lots of those people who can access healthcare cannot do so due to the cultural incompetence of healthcare providers. So we have to strengthen the capacity of the healthcare providers as well as we aim to promote gender and inclusivity through other channels. With that, I would move to the audience and take one more question.
I'm so sorry. I have a lot of things to say. So thank you, Dr. Alicia and Ms. Naomi, for your presentations. Actually, I also have another recommendation, which I just realized while listening to your presentations. Actually, they're very insightful presentations. Perhaps I asked myself, where can we start in doing action for health inequality, or to have health equity? Perhaps probably we should start with um, tweaking our methods doing clinical trials, because for example, I've noticed that during clinical trials they only focus with cis male or cis female, basically the two biological sex that we always know. But there's also another form of sex called intersex, and they are not part of those clinical trials. For example, they can also get cancer, they can also get TB, they can even COVID-19, they can also contract that. But there are no study focusing on intersex people. And also, I also want to focus those who are trans people. They also are not part of those clinical trials, because I asked actually my mentors, why is it so? It's because they are taking hormonal therapy that perhaps that could deter the treatment, the study. But I will go back to the answer that they can also contract cancer and other forms of diseases. So perhaps we could intervene, or we can change health inequity by starting with our processes in our research methods, especially in clinical trials.
Alicia, would you like to respond?
Sure, thank you for that comment as well as question. So I want to offer that this is very much in the nature of why I'm stressing decolonizing data. But what I want to offer is that we have had people who identify as intersex and transgender in our research, and our societies make them so stigmatized they were never going to identify that way in the first place, right? So it's not as simple as saying, well, we just need more clinical trials for these individuals. We need to make it safe for these individuals to even identify who they are and be a part of these trials in the first place, right? And that has everything to do with what questions are being asked, who is asking them, who is funding them, who's in the room to talk to these individuals. And so I try to keep it at a very practical level when I offer comments and thoughts. And so I can give you umpteen examples of times where I've had a client come in or an individual seeking one of our services come in. When they start the conversation with me, they're a cisgender male, they identify as African American, and that's that. But as the questions go on, as we start the counseling session, as we go further into who they really are and why they're actually there by the end of it, I'm actually a trans woman. I didn't trust you when I sat down, and that's why I didn't tell you X, Y, or Z. So Naomi was saying this before, we cannot keep producing data that is not for the people on which the data were collected. So you're right, we need more of that data, but we've got to overhaul this entire system because we're never going to find those individuals because they don't have any reason to trust us, identify that way in the first place, and then be involved in these clinical trials that have never been centered around them or their biomedical needs. I cannot tell you how many providers don't understand that when a woman or an individual of non-binary transgender experience who is assigned female at birth has a choice, they're not going to choose whatever your clinical drug is over the fact that they need birth control. And if they're not clear on if there's interactions or not with that drug, they're not taking it, and that's it. So until we have clinical trial PIs and leadership that understand the value system and the assumptions we make have to also look different for our clinical trials to be diversified, honestly, I would steer clear of if I was identifying that way, I wouldn't be a part of these clinical trials. We're going to waste their time. We're not going to use the data appropriately. We're not going to collect it appropriately. I would tell them to not be in it. And I am one of those PIs that has clinical trials. So I'll leave it there, but I don't want to say that what you're saying is not important and true. I want to offer that there's all these other things that have to happen for us to actually accomplish that.
Thank you. Do we have more questions? Because we still have time. We can take 2 to 3 more questions. Yeah, so we will take one question from here, and then number 2, and then number 3. Yeah.
Hello. Hello, my name is Claire, and I'm a rapporteur today, and I'm a second-year medical student here in Bangkok. So I first just want to preface first that I'm still really new to this field of gender and sex roles, but I found all of your presentations today really interesting. So I've been curious about the roles of gender and sex in children these days, specifically about how they're learning about these new ideologies, since I've seen like recent new curriculums where elementary school kids are learning about the gender unicorn, or how minors today are going through transgender surgeries, or how these children are being raised as non-binary. So I'm curious if these children, if or how are they capable of making these big life decisions from a very young age, coming from like a healthcare perspective.
Oh, right, a very important one. Would any of you respond?
Thank you for this question. I want to throw out there that there's a lot of layers to the considerations that you've raised, but every last one of them goes back to autonomy. And in particular, I'll focus on bodily autonomy, right? So I want to note that within your question, you're asking about whether or not these children, these young, very young voices, are really capable of deciding for themselves if they want to undergo something like a gender reaffirmation or affirmation surgery, what have you. I would offer that that very much depends on context, because if I live in a context in a community that has no concern with childhood marriages and with young children being put into institutions such as that at a very young age, then that level of autonomy needs to be applicable and available and respected in other contexts as well. So there's definitely a cultural kind of component within your question. And the other answer I would say is that there is no perfect way to know that these children are completely capable of deciding to be involved in such a procedure. But what we can do is advocate for bodily autonomy at all ages, at all levels, regardless of your gender, of your sexuality, and your sexual orientation, and foster a conversation about that as early as possible, because the best way we can ensure that level of capacity and autonomy is to give these children the space to ask the question so they can be more informed if they make that decision, if they tell their parent they might want this, that, or the third. So I think a lot of it has to do with respecting their autonomy and assuming it's there in the first place, but cultivating it, giving there to be space so they can educate themselves if they so choose, and then respecting what that choice really looks like in that context as well.
Right, so before we go to the audience, we have Dr. Mina Kang from Korea with us. And she delivered a fascinating presentation. So I wanted to ask a question to Dr. Mina. Dr. Mina, you spoke about changing the perceptions, and you nicely laid out an agenda or a framework to empower women. What problems do you think can come in the way in terms of implementing the framework that you have proposed?
Um, well, that's a good question. I think actually after hearing all the discussions, I was thinking about what's the meaning of decolonization. Um, it's all about breaking our biases and stereotyping. And um, my answer to your question is actually the biggest hurdle or barrier is our biases and stereotypes. And it is there are many different levels from policies to individual perception. Across all these different levels, the hardest, the most difficult area that resists any efforts for decolonization is our perception, which is based in long history. And actually, I noticed that someone mentioned about Western medical system or Western medical practices. And I was wondering, well, what's the difference between Westernized and Western and Eastern medical system on this, on this issues? Everything is based on our norms and our beliefs and our culture, and which has been shaped by long history. And regardless of actually Western and Eastern history, colonization of our perception and stereotypes and biases have been formed in such a way. And I think it is most difficult for no matter what nice way of making changes and nice efforts. I think it's the biggest hurdle for implementation of all these strategies or suggestions will be and should be our deep rooted norms and perceptions. And I'm still wondering how we can change, how we can make changes to those deep-rooted norms and biases and stereotypes so that we can find the true reality and truly make the decolonization of our thoughts.
Right, so your point is well taken. We're almost running out of time, but we promise to take a couple of questions. We'll go ahead with them, but please try to be as brief as you can in your question.
All right, thank you for this opportunity to ask this question. As we all know from the pandemic, we know that misinformation kills. And my question is for all of the panelists, and I would like you to answer that based from experience or from aspirations. Media, as you all know, regarding gender, either established or propagated stereotypes in society, and it can make or break the progress that we've already made. And I'm significantly happy with the progress that we've made with portraying gender in media now. However, there is still some portrayals that are, what do you call this, backward in a sense that would portray people of, for example, gays as these funny comedians or people that would have no progress in life or would and such and such. My question is, how can bodies of research or organizations or ministries of health, because as we all know, you all have your own forms of communication channels. How can you creatively work with media channels, for example, and not only mass media, but also entertainment, such that the facts that we've generated and that we've garnered would be integrated into their work, and we would ensure a factual representation of the gender spectrum. Thank you.
Sure, thank you. So that's a question for all.
Yeah, maybe I can take that. To say that for the longest time, media has brought about influence when it comes to communication, and it is a tool and a strategy actually that you cannot talk about advocacy without media. You cannot talk about awareness without media. So centering media and meaningfully engaging them, not just by the mere fact of inviting them to cover your story or to publish your story, but co-creating with them, training them to actually have that that knowledge with time of appreciating that gender is an intersectional kind of approach, as well as the language itself when it comes to the inclusivity. How then do we ensure that we not only talk about or how do we creatively ensure that we have a shared value, you know, when it comes to communication, or how do we bring them, those who are not even in support of our agenda, or those who don't believe in don't support queer conversations, for example. How do we find a shared value within our conversation? How do we leverage on that and ensure that this communication is more, the information that is shared out there is more inclusive? And as much as some might not want to directly communicate that, how do then we ensure that it is kind of inclusive? It includes like languages that are palatable to the context, just like it was alluded. So working with them, co-creating with them, training them, building their capacity to appreciate and finding the shared values within these conversations. Yeah.
I just wanted to add something very small. I mean, I can only really talk about this from my experience as a dark-skinned Black woman living in the UK. And often, you know, representations of people who look like me are not very positive. So I tend to share and uplift any representation in the media that I feel represents me well, represents me how I see myself, and you know, be those those things that are created by the smallest of creators. I retweet, I share, you know, that's the image of myself that I want to see being put forward. And so I think it's also about supporting creators who are, you know, creating imagery and media that you feel represents you. I think that's really important.
Excellent. We'll take one more question because we are a few minutes over on time. So please go ahead.
Thank you so much to all the panelists. I just wanted to know what would be the best approach that we can apply to promote inclusivity in societies or environments that are not so flexible or accepting in terms of gender and sexuality. Because the country that I belong to, Pakistan, where after the introduction of Transgender Rights Act, government faced a severe criticism and backlash from the religious figures. So what do you think, in your viewpoint, what would be the best approach that can be initiated? Thank you.
How to tackle the governments?
One of the things that we need to really be as activists or whatever we find ourselves in is to make sure that we are mapping our opposition. Knowing what they're thinking, knowing the strategy will help us in terms of countering the narrative out there. And part of that is also ensuring that we're doing the VCAP training, whether it's not the practical training, but we have positive messages out there. Our messaging is also one of the things that are going to sell our advocacy, because the opposition are regrouping, they are mobilizing, they are well coordinated, they have the messages, they have what is clearly rating what they want to counter. We need to look at it and use positive messaging. I think positive messages will help to change a lot of mindset and not just going after, oh, the opposition said this, I'm going to say the next thing. No, we need to reflect, regroup as they are regrouping, having meetings like that, unpacking what's the reality around gender and inclusivity in healthcare. I think going to help us moving forward.
Thank you. I know we have a couple of more people who wanted to ask questions. So with panelists' permission, if you say we can spend a few minutes, because I don't want to exclude anybody. Yeah. Yeah, so we have to be inclusive. Please go ahead.
Hi, so I just wanted to note that there was a lot of mention on like gender inequity throughout this presentation, but I wanted to ask about gender inequity amongst healthcare professionals itself, like not just the general population, but specifically amongst specifically amongst healthcare professionals and how that would affect global health and like healthcare delivery.
Yeah, I mean, I can talk to that. There is a lot of information in that delivered by women, led by men report. But, you know, I can even speak to that sort of from my own personal experience working as a doctor in the UK. You know, I've been a doctor for 10 years. And as I've progressed from an intern to a more senior doctor, you know, people that look like me, you know, in my position are not very common, you know, in hospitals. I mean, I've been called everything from, you know, a nurse to a cleaner to, you know, everything but a doctor. And so this is very much something I live. I try not to let it deter me. In fact, I think it very much fuels my fire, you know, and I think not so much for me, but just making sure that I'm paving the way and creating that path for other people to come behind me. And actually, that's the thing that motivates me the most, so that actually when people come into the hospital and they're looking at the attending, it's me, so that someone else won't be confused about who, you know, a younger, you know, a Black female doctor is. I think, you know, and I recognize that you know, I'm speaking sort of from a position of privilege. You know, I live in the UK where actually, you know, we are relatively progressive in terms of, you know, gender equality. And this may not be true in you know, other countries around the world. But as I said, I think I do a lot of this work and I make a lot of noise so that I can make the world fairer for other people who are coming behind me.
Thank you. Can we have one more question?
So actually, I was gonna ask like a similar question to her about the barriers of our gender inequality in regions where religions or like cultural or social norms come into play. Would you like to like add more on that topic, or if not, I have another question. Would some of you like to add more on that topic?
So is this question for Dr. Mina Khan?
Pardon? Oh, it can be for all panelists.
Right.
Sorry, do you mind repeating the question?
Oh yeah, he also wants to add something.
Well, may I add something to her question?
Sure.
Let me introduce myself. I'm a dentist. I'm graduated as a dentist. But after graduating, I moved to Chiang Rai, which is the most northern province of Thailand. And I worked there as a teaching assistant in public health. So one of my jobs is to teach students and also in community work. So one of my community experiences, I'm going into the community which in Chiang Rai, there is a diversity of like different like native Thai and also the Hill tribes. I can keep going on about the Hill tribes. There are like over 10 tribes in Chiang Rai, in the northern part of Thailand. But something I found in the community is that there's actually a problem which will relate back to her question about culture. One thing I found, especially about the Hill tribe called the Akha, the Hmong, which is the, what do you call them, the Hill tribe in the poverty. So one thing I found is that the students in the age of probably about 10 or 12, they were forced to marry at young age. And I found that from the school that we brought the Hill tribes from, they actually live in the hill. We brought them down to the ground to study in the school. And at the end of the semester, when they go back to the Hill tribe to stay with their parents, they don't get a chance to come back because they were forced to marry. And for me, I feel like that is like a kidnapping to the children, but for them, it's normal in their culture. The question that I'm going to ask is, I might add to her question is that for them, it's cultural acceptability. How do we address the problem?
Yeah, maybe I can take that, given that my context is also very limiting in terms of autonomy and even expression. And this is majorly because of the culture and the religion and how we have approached it as advocates, appreciating that this is a long-term kind of a solution, that we cannot say we want to tackle it and see change tomorrow. So this is a long term, and it's really tied to the behavior change and communication that really centers the values of the other, of the cultures, as well as our values, and seeing how then can we merge, mapping out the cultural leaders, mapping out some of the religious leaders to work with, to be champions of our, to be messengers of our messages, to be the ones that are actually speaking about this. And how do we map them? How do we engage them meaningfully? How do we ensure that they are appreciative of these kinds of conversations and narratives? Building their capacity and ensuring that they have the right information, they have the right understanding of the issue, they have seen the shared kind of values that we're coming with, and leveraging on that acceptability of them being the ones now to share the message out. I think that could be a first step towards now the long-term kind of solution. Appreciating that it's a long term and ensuring that we map out our different champions within these cultural setups. Is it a cultural leader? Is it a religious leader? Is it a group of those of the retrogressive kind of societies? Mapping those and working with them, training them, capacity building them to understand the issue within a shared value kind of approach. Yep.
Thank you for your answer, and sorry for interrupting your question.
Thank you for adding, and thank you for your answer as well. So the other question I would like to ask is that right now we're focusing on like women's rights and also the LGBTQ because they are sexual minorities and they need to be visible, they need to be heard. But I think we all want to gravitate to a common goal, which is everyone is respected, everyone should have like rights regardless of their gender and sexuality. So I would like to ask if you have like any ideas about the ways that the ideology can be shifted from like the present one to the ideal goal that you've all presented.
All right, so what are the ways through which we can promote or maybe reinstate the health rights or the human rights of people with diverse sexual and gender identities and women? That's the question, I believe.
I mean, I feel like that is the ultimate goal. That's the ultimate goal of feminism. You know, feminism is about achieving equality by uplifting women. And similarly, talking about gender egalitarianism, it's not about prioritizing women necessarily. It's about everyone being brought to the same level and all having equal access. And I think perhaps what you're referring to is actually we are taking an equitable approach. So we are saying actually in this moment in time, those who have been marginalized, women, those who are non-binary, you know, the people of color, who, however they may identify, they are not achieving the same potential, being given the same opportunities as men. And that's just the truth, you know. The ultimate goal is that we all live in a society where we are all treated as equals. But I think in order to get there, those who are disenfranchised need the focus of society right now. And, you know, that's the way I feel about it.
And more importantly, we need change in legislations, change in policy, and ensuring that it caters to the needs of all. That what he just stated about the early childhood marriages. When you hear about childhood marriages, you think about developing country. I don't think you would think about a country like Thailand. But yes, we need to change our legislation and policy to be of human rights focus. We also need to ensure that I can go back again, building movement. Movement building, providing education is very key to ensuring that we have equal care for all, and equal health care for everyone. Yeah.
Thank you so much.
All right, thank you.
If I can add, oh, well, if I can add just one more,
Yeah, sure.
I think creating a space for people who were unheard is the most critical way to debunk the myths of culture, because oftentimes we take stereotypes and biases as our culture, historical culture. But if we look really deeply inside, the culture itself does not reflect people's voice, unheard voices that are powerless with disadvantages. So I think as a policy level or even a community level, it is very important for these people and create a space and sphere for these people to speak about what were the difficulties, what are the disadvantages, what are the problems that they have been experiencing because of these lingering culture of exploiting or stereotyping the group. So I would recommend creating a method, sphere, and taking the approach of truly participatory of everyone, especially giving more spaces for people who have been unheard so far, so that we can debunk the culture, myths of culture.
Thank you, Dr. Amina. Your point is well taken. So what we have learned from this session is that gender and sexuality, they certainly play a huge role in healthcare, and that injustices against people with diverse sexual and gender orientations um, and against women are not produced in a vacuum, but there are some structural issues that we have to deal with. And it all depends on how patriarchy plays out in society, how heteronormativity plays out in society, how heterosexism plays out in society. And we know that women and people of diverse sexual and gender identities, they are victims of the marginalization, but at the same time, they have agency. So they have an agential side, they have capabilities, they have capacities that we need to document through research. And those capabilities and capacities have to be tapped in or tapped on in advocacy. And we have to fight on various fronts. We just not have to be limited to creating awareness, but we have to promote education, different sort of education, mainstream education, vocational or skilled education or professional education, health education, health literacy. We have to improve people's access to healthcare. We have to create opportunities for jobs. So there is financial independence is there, which also plays out a huge role positively. So we also have to strengthen the capacity of healthcare professionals. So women and LGBTQ people are dealt with appropriately in healthcare settings. And finally, we have to decolonize data and research. So with that, I would like to thank all my panelists for the powerful presentations. I still feel really energized by listening to all of you, and I really thank all of the audience sitting here, being so engaged and interactive and asking lots of questions. So we are so thankful for your presence here as well. If you have any questions, you can certainly reach out to our panelists via perhaps Twitter or email. You can Google them, and you can, if you have any questions later on, please feel free to reach out. Thank you very much.